Everyone. This is Jen Hastings, and we have the greatest honor and pleasure of reconnecting with Marissa Raymond Fleisch, who is Assistant Professor of Pediatrics at UCSF and involved with many things there, both the Director of the Adolescent and Young Adult Medicine Fellowship in the Division of Adolescent and Young Adult Medicine, and also part of the Philip R. Lee Institute of Health Policy Studies. And we're following up on our learning webinar together October 29th when we discussed racism in healthcare, confronting chronic stress and chronic disease. And we did have a question and answer period after that wonderful session, but there were many questions, actually 10, that we did not get to. So Marissa, thank you so much for agreeing to join us. And I'm going to read off the questions to you. And thank you for taking the time to meet with us again. I know this will mean a lot to folks. So thank you.
Sure thing. And I welcome any kind of follow-up or clarification you want about any of these questions as we go.
That's great. It means so much. So the first one is, can you speak to racism that you and other healthcare professionals have experienced while caring for patients?
I think racism in our professions, in the helping professions in general, can come in so many different forms. And when we're engaged in clinical care, of course, it can come from our patients, it can come from their families, it can come from our colleagues. And I think all of these are really challenging to manage. I know for me personally, experiences of discrimination that come from my colleagues in medicine have been the most difficult and corrosive. Whether it's sort of hearing my colleagues make disparaging comments about Mexican patients or Mexican American patients or Latinx patients or other underrepresented minorities, patients who have similar life experiences to mine, or to hear them disparage myself or other colleagues on the basis of race or without implication. And of course, this also comes up with patients, and many providers face discrimination from their patients from a wide variety of things. I've had the privilege of working not only with other minorities in medicine, but also people of different religions, and of course, people of different genders. And, I think all of those things can also, all those intersectionalities can also add up when it comes to experiences of discrimination with patients. I think when we're talking specifically about the experience of a patient or their family being discriminatory, I think it can fall under many different buckets. The hardest is often managing experiences of microaggression. I think one of the reasons that those experiences can feel so difficult is that our reflex is often to try and process that and to kind of have this experience of being able to go and talk with someone that we trust about it and say, that was awful, right? Like, I'm not making this up, right? And if you aren't in a work environment where your colleagues are fully able to understand that, or just able to trust your experience and accept your experience, and you are sort of deflected or your experience is diminished, it can really have a sense of gaslighting, of compounding. And so I know we had a lot of discussion about sort of what can individuals in the audience do. And I think this is one way that any of us can support colleagues who have experienced discrimination in any capacity, or microaggressions in any capacity, but particularly with patients. I think some other things that you really need to keep in mind are that, experiences of discrimination from patients and families impact your work environment, just like experiences of discrimination from colleagues. And it is okay to really think about making a work environment that is safe and appropriate for you. And so if you're repeatedly running into problems with a patient, I think a few ideas come to mind. There should be institutional policies in place everywhere about sort of the limits of what patients are allowed to engage in terms of verbal abuse with staff. And that comes in lots of different forms, but discrimination and microaggressions have to be among them. And I think that there should be clear policy in every practice about what those limits are, under what circumstances patients can be transferred to other providers, either within the practice or outside of the practice. And this is also a situation in which white colleagues can ease the burden of minority providers if this is coming up repeatedly. I know for me, this has been hardest in cases of sort of profound mental illness, where this is a component of that mental illness. And yet it doesn't change my experience in the work environment that it creates for me. And I think we all have patients that we discover for different reasons that we don't have the capacity to care for. And it's okay to set limits for yourself related to repeated experiences of discrimination as well. And lastly, I'll say that, someone once told me that anger is very often a reaction to feeling threatened. And so in some situations in which I've experienced really overt interpersonal racism, it has been when a family or a patient is scared, when they feel backed against the wall by a new diagnosis that's scary, or I'm explaining to a parent that they can't check their child out of the hospital because it's too dangerous, things like that. And, I think that recognizing that really trying to address those outbursts as fear and a sense of being threatened can often diffuse them. And I do think that when done well, it is okay to share with the patient and the impact of what they've said, both in terms of, I think most importantly, sort of in terms of how it might be difficult for providers and staff to care for them if they are saying certain things. Like, it makes it very difficult for us to focus on the care that you need if we're talking about this. I think it's really sidetracking us from what we need to do to take care of your child. Things like that, I think can be helpful for just reminding people why we're there and that we all have the same interests at heart. So I think, that's a long answer to say there's a lot of different approaches, but there absolutely does need to be sort of a systems level approach for when these issues become chronic and insidious.
Thank you so much. There's another interesting kind of follow-up question sorts. Do you think that terms like my patient or your patient may contribute to inequality in healthcare?
Yeah, I thought this was a fascinating question. I think that, I guess the first thing I will say is, sure, I think they could. And I would say in my experience, I haven't run into these issues that I'm aware of. I haven't run into them personally, and I haven't gotten feedback about them professionally. I do tend to be someone who I feel like if my patients are calling me doctor or, if my patients are calling me Dr. Raymond Flesh, I tend to use last names for them as well, to show a similar level of respect and deference. And this is definitely true for my adolescent patients' parents. And I try, and there is a tendency sometimes, I think in some cultural contexts, for parents to steer their children towards calling me Marisa. And I try and gently guide back to being Dr. Raymond Flesh. I think it helps me set boundaries and things like that, and kind of have very clear roles. But I find that if anything, what I would say in my personal experience is that I found that there's a sense of connection, alliance, and commitment that comes with these labels, my patient. And I think that equally powerful, and I've seen many times invoked, the label my doctor. And so, I think that the bottom line is this could really be different in every clinical environment. And I think it's always okay to talk to your patients about how to talk with them, about what language to use. There could be really big differences in different languages as well, in terms of level of familiarity that's appropriate. And I think that's something to consider, particularly in thinking about Spanish-speaking populations and how formal they may or may not be with you. And then I think I mentioned this during the talk, but I think that one thing that is always the right answer is to involve your community in this decision, right? And so if you do sort of follow the big picture advice that I gave about trying to think about establishing an advisory board or getting more input from patients in your patient population about how your practice is running, this is a great question to bring to them. But I wouldn't assume anything without asking.
Thank you. Very helpful. What are your thoughts on this comment or question? Why is the Asian American population less effective? Are there more protective factors or less contact with medical providers to monitor and gather data? Any thoughts on that?
I wasn't 100% sure what this was referring to. I think it could be a couple of different things. I think this question could have been related to sort of health disparities. And I think it's possible, I guess, that it just occurred to me right now that it could also be related to like ACEs scores in the second half of my talk. So I'm not 100% sure what the original source of this question was, but I will say a few things about it. One is I don't study Asian populations, so I just want to sort of put that out there as a disclaimer. This is somewhat outside of my scope of knowledge. And I think that it is always wise to assume that there could be, and for almost every population, there are innate resiliences that might be kind of leading to positive health outcomes that we're not measuring or we're not seeing as well, or that are just maybe we don't know how to access and to make show up in the medical literature, but I think that's always possible. In terms of less contact with medical providers, that's not generally true as far as I know. I think that most studies that I'm aware of have Asian Americans at or above the level of access that most Black populations have, at least. So I don't think that it would just be kind of a matter of monitoring if we were talking about ACEs. I think that there can also be a lot of cultural differences in terms of sort of what people perceive of as traumatic and not. And I think that's, that is possibly a source of difference. In terms of sort of differences related to health disparities, I think that another thing just to remember is, while it is absolutely true, without a doubt, that Asian communities in the United States have been targeted with discrimination. That is really obvious historically, from far even before the internment camps during World War II, and has continued to be very true in the COVID era. And we still know that in the United States, we live in a country where Black and brown bodies fare worse by most indices of discrimination experiences, as I reported in the data that I shared. And I think that likely plays out in the medical setting. And so when we're thinking about kind of, if we're talking about this question in terms of health disparities, I think that could be part of what contributes for our African-American or Black communities and our Latinx communities. Yeah, I welcome your thoughts, Jen, if you have any other sense of kind of what exactly this was going after.
Yeah, I don't know. And so we can follow up but I think your answer is helpful. Okay. I'm going to move on though, within the Latinx population, because there is so much diversity, the person is curious whether your research done in Monterey noted any of the distinctions for the Mexican indigenous population. And we know there are many.
Mm-hmm. We did have some participants. So in order to, one of the structural barriers in our study was that in order to participate in the study, you had to be fluent in English or Spanish. And so that probably ruled out some newer indigenous immigrants, absolutely. And then the remainder that we had, we certainly did have a few that were fluent enough in Spanish to participate, but it was such a small group that we haven't sort of analyzed them as a subgroup in any way. But I do think it's a really important question. I do think that it's a group that's likely to be really have very unique challenges. And I know that it's a group that within the sort of medical community in Salinas, there's a lot of efforts to make sure that community has access to care. I know that Natividad has translators that they've recruited from sort of indigenous populations to make sure that there's adequate medical translation, and that this is a small, tight-knit group of people. This is not the sort of situation where those, you can always just call language line and get the right interpreter. Right. And so, I think this is a situation where maintaining that sort of touch with the community is really important medically, but we did not have the capacity to do that in this research project.
Got it. That makes sense. There's a question about the suicide attempt rates that you showed. For the person who asked the questions, it didn't land for them. They didn't seem accurate. Can you comment on the data that you showed to us?
So that is Center for Disease Control data from the MMWR, the Morbidity and Mortality Weekly Report. And It is national data, and I think that one of the sources of confusion with this data is that the data that I presented is about relative differences, not absolute numbers. And so I'm just glancing over kind of at my slide for a moment. And the data that I shared with you guys was that for Latino children in particular, 34%, they were 34% more likely to attempt suicide in high school than their white counterparts. This is not the same as saying that a third of Latinx children attempt suicide, if that makes sense. This is a relative risk. So it means that they are more likely than white peers to do so. And I think that, I apologize if I misspoke in any way or didn't make that clear enough, but my guess is that that's the source of confusion.
Perfect. That's really helpful. So the next question comes from one of our medical directors in Santa Cruz. I lead a community health center with a patient population where about 50% identify as Hispanic Latino. Nearly 100% of our medical providers identify as white, less than half speak Spanish. We are told that we can recruit for Spanish-speaking ability, but we are not allowed to recruit for providers of color who share the cultural and ethnic background of our patients, citing essentially reverse discrimination. How do we address disparities in the healthcare workforce through recruitment?
Well, when I originally saw this question a few weeks ago, I'd been hopeful that we would have passed a proposition in California that might have changed hiring practices around this, but we remain in the same boat today. And so, I think that I'll share with you a few things that I know we do at UCSF and a couple of other ideas that might be helpful. If there are people of color in your practice, I do think that they should be involved in hiring. And I think that, at UCSF, when we're hiring for a position, our search committees have to have a person of color, they have to have a woman, and they have to have people from both faculty and staff and different disciplines. And so even if you don't have a lot of physicians, for example, that are minorities, you might have nurses, you might have other administrative staff. And I think that it's reasonable to consider diversifying who is doing these interviews and making these decisions. And then I will say also, this is another really good potential spot to think about community involvement. If you do make that commitment to putting together an advisory board, thinking with them about getting really concrete about what are the specific attributes that you're looking for, even if you can't say that you are recruiting someone of color, there are particular things that you might be able to look out for, people who have worked in these communities before, as you mentioned, people who are fluent in Spanish. You can look for a certain level of cultural competency that is and cultural humility that are spoken to by the resumes of the applicants. And then similarly, one thing that UCSF does, I think I mentioned in my talk, is that we require every applicant to create a statement on diversity. And that can be about the ways that they bring diversity to the practice, but also their different types of commitment to working with diverse populations, to mentoring diverse trainees, things like that. And I think it can really also show you where allyship might be that you may not be capturing in your interview process. And even if you don't have very many people of color to choose from, say, help you drill down to the applicants who might foster the clinical environment that you're looking to build.
Great. Thank you so much. And I think they do have a community board, but so that might be a place.
And can they be involved in interviews, right? Not just making requirements, but like actually interviewing applicants.
Thank you. The next question is regarding gender. Have you looked at the difference in gender as a factor in pay differences per professionals? Generally, females receive lower pay than males in the same professional level, so there may be even more differences in minority women's income.
Yes, I haven't looked at this a great deal, but I took a quick peek at it previously. And it is true that women are paid less than men. And I believe that this actually is even a bigger effect in medicine than race and ethnicity. I did not present that data, but I believe that at least for some racial ethnic groups, being a female is likely to contribute even more substantially to your pay gap than being of a racial and ethnic minority. But regardless, you know, both have a really significant impact. And I think it does vary by field to some degree.
Yeah. Yeah. So I think I might combine the next two questions. One is asking whether you have any data on advanced practice clinician minorities, so nurse practitioner, physician assistant, certified nurse midwife. And after that, what means are there to increase representation, not just in those fields, but in nursing and in medicine as well? How do we impact the entire system to identify students at critical points in their education, middle school, high school, or even earlier, to assist persons to enter the healthcare workforce?
Yeah, absolutely. So I don't have data on advanced practice clinicians. I've actually looked for it and been unable to find it. I've given this talk for UCSF's nurse practitioner training program before, and have only been able to find nurse like RN and LVN level data. So if anybody out there knows, please let me know, because I would really like to see it. And I think I presented a little bit of that in the talk as well, that you guys already heard. And in terms of increasing representation kind of across all fields and throughout the pipeline, I think there's a lot of work to do all along the way. Certainly, you know, I know that I mentor for a few different organizations that I particularly enjoy, and I do that mentorship because there's a way that it's generative for me. It feels affirming to be able to do that work. It is not a drain. And so some of the organizations that I work with include LMSA, the Latino Medical Student Association, which we have an active chapter for at UCSF, and most medical schools in the country do. SNMA, which is the Student National Medical Association, which is the historically Black organization for students in medicine, and is affiliated with the National Medical Organization and National Medical Association. And then there are many other similar organizations, and particularly in this moment with COVID, I would really encourage people to reach out. I don't know the nursing field nearly as well, but I'm sure that there are similar ones. And one program that I have also really enjoyed working with is Pre-Health Dreamers, which is an organization that is particularly focused on dreamers, largely young people with DACA, who want to pursue an education in any health sciences field. So they have a really wide variety of people who come through. I'm positive that they have people going into nursing, they have people going into dentistry, they have people going into basic sciences, basic medical sciences. And then of course, people going into medicine, nurse practitioners, physician's assistants. And I've really enjoyed getting to know students through that program. And so that's another great place. And then I think starting as early as you can in your pipeline and making at least an informal commitment to stick with people. I think that that's how they get through. I think many people who come from backgrounds like mine have probably had the experience of just the magic that a consistent mentor who believes in what you are doing can be for a growing career, and not to have to be sort of passed on as soon as one is in medical school and kind of have to fight for the next mentor in the line. And I think it can be, again, really generative for us. It can be really meaningful to watch someone's career unfold over time. And in a COVID era where we're all quite good at Zoom now, and that's how we're meeting anyway, you can mentor people across the country even as they move for their careers. So I would say, those are some options. Look for points as early as possible in the educational pathway, and then try and stick with people so that they stick with the field.
That's beautiful. Thank you. And speaking of COVID, I know that we've been reflecting a lot on the effects of COVID on our minority populations. And this questioner wants to know if you know of studies at UCSF regarding the impact of COVID with regard to race and cultural health disparities.
Yeah. So yes, so first I will just say that we have a comprehensive list at UCSF of all of our COVID related research that anybody can access. These are all of our ongoing projects as well as published papers, and it's at coronavirus.ucsf.edu. And so you can access everything that we have in progress or have published there. And I will say that I know, like, for example, within UCSF, we have, we put together, there was a large study looking at rates of coronavirus positivity in the mission here in San Francisco, and then also in people who are commuting out from like the East Bay into San Francisco. And part of that helped UCSF and the San Francisco Department of Health are closely linked and share many faculty members and have really taken a partnership approach in managing the coronavirus here in San Francisco. And so that really helped us as a county target our screening strategies and create more sort of pop-up screening sites for even asymptomatic people who are commuting through those corridors to try and catch more coronavirus cases and make it possible for people to shelter in place in conjunction with other city policies that allow people to stay out while they're sick. So, you know, so yes, I'm positive I don't know all of them. I'm positive there are many that are still ongoing, and I welcome you guys to explore.
Yeah, well, that reference is great. We'll include that in what we put out, and that's our 10 questions. And I know that we're actively looking to invite you back for a follow-up. And thank you so much for your time today.
Absolutely, it was really fun. I really appreciate being able to be involved.
Thank you so much, Marissa. Take care.